Information on mosaic embryos. Note: there is a separate patient information document describing PGT-A, pre-implantation genetic testing for aneuploidy. A mosaic embryo is a diagnostic result from PGT-A testing. Kindly read the patient information on PGT-A before reading the information on a mosaic embryo result. PGT-A is used to determine the genetic makeup of an embryo prior to transfer. Normal Euploid, Diploid embryos show the presence of 23 pairs of chromosomes, 46 chromosomes in total. Aneuploid, abnormal chromosome number, embryos arise because of uneven separation of chromosomes during the formation of gametes, eggs or sperm. This process affects eggs more than sperm and is the reason that increasing female age is associated with reduction in pregnancy rates, higher miscarriage rates, and increased risk of survivable genetic syndromes. Essential information: aneuploid embryos have no potential for healthy outcomes. They are associated with implantation failure, lower pregnancy rates per embryo transferred, miscarriage. 70% of first trimester miscarriages result from aneuploidy. Genetic syndromes: trisomy, Downs, Edwards and Patau syndrome, and monosomy, Turner syndrome. Aneuploid embryos are not transferred. In untested embryo transfer, aneuploid embryos are transferred unwittingly and account for the lower pregnancy rates, higher miscarriage rates, and greater risk for genetic syndrome in comparison to euploid embryo transfer. Euploid embryo selection seeks to avoid the risks and outcomes associated with aneuploid embryos. PGT-A also identifies embryos which are neither euploid nor aneuploid. Mosaic embryos contain a mix of normal and abnormal chromosome number in a single embryo, euploid, aneuploid mosaics. The incidence of mosaicism ranges from 5 to 15% of biopsied embryos. In the absence of euploid embryos, mosaic embryo transfer (MET) offer the possibility of a healthy pregnancy. Essential information: both the egg and the sperm forming a mosaic embryo are genetically normal. During the process of embryo growth through cell division and DNA replication mitosis, an error leads to a subpopulation of cells within a normal chromosome number, aneuploid. The earlier this occurs within embryo development, the higher the proportion of abnormal cells in the day 5 embryo/blastocyst. Mosaic embryos can yield healthy live births. The first report of a healthy live birth following a mosaic embryo transfer was in 2015. To date, there have been greater than 2,700 documented mosaic embryo transfers. Compared with euploid embryo transfer, mosaic embryo transfer (MET) displays significantly lower implantation rates, pregnancy rate, embryo transfer, 2 times higher miscarriage rates. The outcomes following mosaic embryo transfer are affected by the proportion % of mosaicism detected, the type of chromosome abnormality, segmental versus whole chromosome, the number of chromosomes involved, single or complex mosaic. Low-level mosaic embryos, less than 40% detected aneuploidy, have a comparable reproductive outcome to euploid embryos, less than 20% detected aneuploidy. It is important to recognize that mosaic embryo transfer is generally reserved for cases where all euploid embryos have been used. In women with recurrent implantation failure, greater than 3 consecutive negative transfers, the outcomes using mosaic embryos may reflect underlying uterine, pelvis, or systemic abnormalities. Segmental aneuploidy, a portion of a chromosome missing or added, is generally preferred over a whole chromosome aneuploidy, showing lower concordance rates between TE and ICM biopsy results compared to whole chromosomes. Complex mosaic embryos show abnormalities affecting several chromosomes. High-level, greater than 40% abnormal cells detected, and complex mosaic embryos are not considered suitable for transfer. The main concern in transferring a mosaic embryo is whether there will be a higher frequency of congenital abnormalities in the offspring/children. Currently, there are 2 reported cases of fetal aneuploidy resulting from an embryo identified as mosaic for the same chromosome in the PGT-A test. The persistence of mosaicism within the pregnancy is 1.2%, which not different from the 1 to 2% of chorionic villus sample results indicating mosaicism in the general population. A review of 25 publications found less than 1% of 2,759 mosaic embryos transferred led to an ongoing aneuploidy related to the original PGT-A result. Mosaic embryos give pregnancies with healthy outcomes. How is this possible? The answer lies in 3 principles. 1. Trophectoderm, TE biopsy is not a perfect representation of the embryo's entire genetics. 2. The embryo can autocorrect its chromosome number during development. 3. Misinterpretation of PGT-A results. In the analysis of the chromosome number using PGT-A, pre-implantation genetic testing for aneuploidy. The DNA is extracted from a few cells removed from the outer layer of the embryo, a trophectoderm (TE) biopsy. The trophectoderm cells give rise to the placenta and membranes of the future pregnancy. The inner cell mass, ICM, gives rise to the fetus/baby in the future pregnancy. A few biopsied cells from the outermost layer, trophectoderm, cannot be a true reflection of the entire embryo genetic makeup unless the aneuploid cells are evenly distributed throughout. The trophectoderm is the placental precursor and is not necessarily identical to the inner cell mass from which the fetus will develop. Trophectoderm biopsy is an indirect assessment of the entire embryo's genetic makeup. Mosaic embryos can have various distributions of normal and abnormal chromosome populations within the embryo. This can contribute to a trophectoderm biopsy, which provides an inaccurate assessment of the genetic makeup of the ICM, inner cell mass. Concordance between biopsy results from trophectoderm versus the inner cell mass. These vary according to the degree of mosaicism and the type of chromosomal involvement, whole chromosome versus segmental. Euploidy, 92.2% concordance. Aneuploidy, 75.9% concordance. Mosaic, 42.6% concordance. There is a high level of concordance between TE and ICM biopsy in aneuploid embryos, as these represent a meiotic error, pre-fertilization, and are evenly distributed throughout the embryo. Low-level mosaic results from TE biopsy are rarely confirmed in ICM biopsy. Conversely, high-level mosaicism in TE biopsy showed complete aneuploid. Autocorrection and embryoplasticity. Extended culture of mosaic embryos biopsied on day 3 showed decreasing levels of mosaicism at day 5 when rebiopsied, and 71% were found to be euploid when biopsied after culturing to day 12. Chromosomal mosaicism is an inherent biological phenomenon in pre-implantation human embryos. Aneuploid/abnormal chromosome number cells are progressively removed from the embryo through programmed cell death/apoptosis and reduced proliferation through prolonged cell cycles. This allows for a transition to a higher proportion of euploid/normal chromosome number over time. Within the developing embryo, there appears to be a differential approach to autocorrection between the inner cell mass, ICM, and the trophectoderm, TE. Within the ICM, aneuploid cells undergo increased apoptosis, which rapidly reduces the proportion of abnormal cells. Within the trophectoderm, aneuploid cells display prolonged cell cycles, which reduces their presence, but is a slower correction process. Over time, the net effect is increased euploid cells in the ICM, with a persistent, but shrinking, aneuploid/abnormal chromosome number cells retained in the trophectoderm. There is an asynchronous rate of elimination of aneuploid cells from the ICM and the TE. When comparing rates of aneuploidy in the same embryo, rates of aneuploidy in the trophectoderm is consistently higher than in the inner cell mass. Misinterpretation of PGT-A results. Accuracy of PGT-A diagnosis? Technical considerations in PGT-A. The biopsied trophectoderm cells contain a very small amount of DNA, which must be amplified, increased in volume, to allow for testing. The DNA is extracted from the biopsied cells and fragmented into thousands of small segments. These small segments are specifically chosen and referred to as a library. DNA consists of 2 strands arranged in a double helix, joined together by hydrogen bonds, between complementary nucleotide bases. During the copying process, the DNA strand is separated down the middle into 2 single strands. DNA building blocks, nucleotide bases, are integrated and attached, forming a copy of each DNA strand. This process is repeated multiple times, resulting in enormous copy numbers of each library strand, amplification, until a specific read depth, specific number of copies, of each library region is reached. Fluorescently labeled nucleotide bases are included within the pool of free nucleotides and are included in the copy strands of the library. Essential information. Next-generation sequencing, NGS, uses ultra-high-resolution imaging technology to compare included nucleotide signals from the tested embryo to a known normal sample, sequencing. The diagnosis of a mosaic embryo is not made using visual observation of euploid and aneuploid individual cells. Instead, it is inferred from collectively analyzing the extracted DNA amplified from a group of cells and observing an intermediate copy number. This is not the same as having a karyotype of the individual, rather a quantitative comparison in read depth/copy number between the biopsy and a reference library, known to represent euploidy. A genetically normal embryo will be identified as having 2 copy signals for each tested area. Aneuploid embryos will show 1 or 3 copy signals, indicating missing, monosomy, or additional trisomy respectively. In cases of aneuploidy, the abnormal read depth/copy number is represented by a deviation from the normal copy number 2. In both cases, a trisomy, 3 copies of an individual chromosome, is illustrated. There is considerable overlap of signals, a phenomenon termed signal noise. Cutoff values for embryo allocation must consider this analytical noise. Euploid embryos less than 20% abnormal cells detected. Aneuploid embryos greater than 80% abnormal cells detected. Between these we have low-level mosaic embryos have less than 40% abnormal cells detected. High-level mosaic embryos have greater than 40% abnormal cells detected. Mosaic embryos express an intermediate copy number between euploid 2 and monosomy 1, a monosomy mosaic, or between euploid 2 and trisomy 3, a trisomy mosaic. The ratio of abnormal to normal signals is expressed as a percentage. This is interpreted to represent the proportion of abnormal to normal cells within the biopsy, and presumably the embryo. The assumption that an intermediate copy number indicates the presence of normal and abnormal chromosome number in the same embryo may be the result of technical noise. Suspected mosaicism was undetected in previous methods of PGT-A. This included PGT-A using FISH, fluorescent in situ hybridization, ACGH, array comparative genomic hybridization, and SNP, single nucleotide polymorphism microarray. PGT-A using NGS, next-generation sequencing, is more sensitive, and now identified more embryos as being mosaic, which would previously have been assigned euploid, low-level mosaics, or aneuploid, high-level mosaics. Artificial mosaic results may occur because of an inadequate biopsy, too few cells, undetected sample contamination, e.g. maternal cells, analytical/algorithm inaccuracy. As a result, rebiopsy of embryos showed a euploid or aneuploid result in 57% of embryos previously reported as mosaic. The transfer of low-level, less than 40% aneuploidy mosaic embryos results in healthy outcomes, because many of these embryos were in fact euploid and never actually mosaic, false positive. In contrast, high-level mosaic embryos, if rebiopsied, 65%, show uniformly aneuploid inner cell mass, and were in fact aneuploid, not mosaic, false negative. Prioritization of mosaic embryos for transfer. Mosaic embryos are a heterogeneous group with variable potential. To understand the potential for success and risk, it is essential to attend a counseling session with a registered genetic counselor prior to considering the transfer of a mosaic embryo. Outside of this specific advice, there are some general rules which apply to selecting mosaic embryos for transfer. Low-level mosaics are transferable. The lower the percentage aneuploidy, the more favorable. Segmental partial chromosome aneuploidy is preferred over whole chromosome aneuploidy. Chromosomes associated with live-born syndromes, intrauterine growth restriction, and uniparental disomy (UPD) are. Single chromosome are preferred over multiple chromosome aneuploidies. High-level or complex abnormal mosaic embryos are not transferred. Similar mosaic embryos are transferred based on classical embryo grading. Viati et al. 2020. Prenatal testing following mosaic embryo transfer. In pregnancy following a mosaic embryo transfer, you may be recommended to undergo prenatal screening. ACOG, American College of Obstetricians and Gynecologists, recommends prenatal diagnosis be offered to all patients who underwent IVF or PGT-A. Low-level, less than 40%. Mosaic embryo transfer, MET, is not an automatic indication for invasive prenatal testing. Genetic counseling is essential for you to weigh the procedure risk versus the certainty of diagnosis benefit for the specific mosaicism identified by PGT-A in the embryo. While some mosaic outcomes will be miscarriage or healthy pregnancy, others may carry a small risk of a live birth affected by a genetic syndrome. Neither Vitalab nor the genetics testing companies can take any responsibility for outcomes following a decision to transfer a mosaic embryo. It is essential that you understand and accept the potential range of outcomes specific for the mosaicism identified prior to its use. NIPT, non-invasive prenatal testing, a blood test from 10 weeks gestation. Chorionic villus sampling, CVS, a biopsy of the placenta from 10 to 13 weeks gestation. Amniocentesis, an aspiration of amniotic fluid at 15 to 20 weeks gestation. Some of these tests are associated with a risk of pregnancy loss. Only one of these tests is a true reflection of the fetal cells, that is, the amniocentesis. Both the NIPT and CVS tests suffer the same limitation as the trophectoderm biopsy, namely that a biopsy of the placental tissue is being used to infer the genetic makeup of the fetus. An abnormal result identified on amniocentesis will be discussed with you, together with a genetic counselor. This may lead to a discussion and recommendation for termination of pregnancy in cases where a risk of a genetic syndrome exists. Alternative options for mosaic embryos. If you are not comfortable to transfer a mosaic embryo, the following options are available. The embryo may be warmed and rebiopsied, although this is not recommended, as it is not associated with any diagnostic value and may compromise the embryo. The embryo may be donated for training of embryologists. The embryo may be discarded. Note: VitaLab will not discard low-level, less than 40% mosaic embryos with the potential for transfer without your written instruction. When low-level, less than 40% mosaic embryos exist, a new stimulation cycle to generate Euploid embryos is not indicated, but may be requested by the patient. Aneuploid embryos, high-level mosaic and complex mosaic embryos, will be discarded automatically.